Hello, everyone. A warm welcome to the ICS webinar series. First of all, I take this opportunity to congratulate and also thank ICS team led by Dr. Sandeep Salvi sir, Dr. Rajadhar, and Dr. Amita Nene for giving us this opportunity and also for their continued efforts to keep this academic extravaganza going on. So today we are here with a brilliant panel of transplant pulmonologists and surgeons from all over the country to discuss with you about all that you need to know about lung transplant. So, without any further delay, let us go into our webinar. And we have Dr. Kapil Iyer to start our webinar with his talk about a pulmonologist perspective of lung transplant. So, as we all know, I mean, Dr. Kapil Iyer doesn't need much introduction, but he's a transplant pulmonologist trained from the UK, and he's been a part of a team that has performed more than 200 lung transplants while he was there. He's also active transplant pulmonologist currently in the country and has done the first successful lung transplant for an international as well as a national patient in Gujarat. Over to you, Dr. Kapil. Looking forward for a brilliant talk from you.
Thank you so much, Chetan. I hope my screen is visible to everyone.
Yes.
Yes,
Okay,
visible.
perfect. At the outset, it feels great because we were waiting very keenly for this lung transplantation session to start of the ILD series. Once again, thank you so much, Amita Nene ma'am, for making this possible. Before I start my topic, I've got a small, I want to tell a small thing to everyone. Please, January 23rd to 26th, is going to be NAPCON Pune. We're going to have a separate ECMO and lung transplantation sessions and a workshop. This will be led by Dr. Rahul Kendre, who's also one of the panelists, and he's got local boy in Pune. So please, we are looking forward to welcoming all of you for this workshop. Please ensure, because this is going to be a state-of-the-art workshop, and we are eagerly awaiting NAPCON Pune 23rd Jan to 26th Jan. Having said that, now what is going to be my topic is I just want to slightly touch upon an overview of lung transplantation. And obviously, I will be talking about the medical perspective. The surgical perspective will be taken care by the next speaker. Now, I'm just going to be talking about the following things: introduction of lung transplantation. What is the history of lung transplantation? In the history of particular importance for me is going to be the sequence of events. I'm just going to touch upon how things were in India and also what is the current status of lung transplantation in India. What are the types of lung transplantation? Because people consider only one particular kind of lung transplantation, but there are also different kinds. What are the indications and contraindications for lung transplantation? What exactly do you mean by the term transplant window? And in the end, I'm going to be giving and talking about black and white data as far as referral guidelines of some diseases to a lung transplant center are concerned. So without wasting further time, let's start with this presentation. Now, lung transplantation, obviously all of us know it has a definite treatment option for all end-stage lung diseases, including COPDs, interstitial lung diseases, bronchiectasis of various etiologies. It can be CF, it can be non-CF, pulmonary hypertension, and basically all end-stage lung diseases which unfortunately are not responding to medical management are the ones which we consider for lung transplantation. In India, obviously, there are a lot of centers which are actively doing lung transplantation. And I know as a fact that there are a lot of centers which are also in the process of establishing a lung transplant program. Now, if you look at this chart, this has been taken from the Journal of Heart and Lung Transplant. You see the bars in purple and the bars in green. The green ones are the ones which represent single lung transplant, and the purple are the ones which represent a double lung transplant. And you can see from the year 1985 onwards, you can see the proportionate increase in the total number of lung transplants done in the entire world, and how the quantity of bilateral lung transplant is much more as compared to single lung transplants. Now, of course, this is a continent-wise data. The green one is what represents North America, which is the most active area to do lung transplantation. The yellow is the one which is Europe, and the rest of the world is summated in the red blocks which are put on top of each bar. Of course, India belongs to the other and the rest of the world, so we are contributing currently to the red bar. It is heartening to know that the quantity of lung transplantation slowly and steadily is increasing, but there is a lot of work yet to be done as far as lung transplantation is concerned in our country. Now, this is a very interesting and a very important, slide. Again, taken from the Journal of Heart and Lung Transplant. This is the 2018 registry data. Now, before 2007, the number one referral disease for lung transplantation done worldwide was actually COPD. And I'm also incorporating alpha 1 antitrypsin deficiency in this. But 2007 onwards, you can see that ILDs are slowly and steadily becoming the number one reason for referral to a lung transplant center. In ILDs, this graph also gives a differentiation between IIPs as well as ILDs which do not belong to the IIP segment. Now, what is the history of lung transplantation? It actually, the very thought of lung transplantation is in the early 1900s, 1907 to be very precise. That was where at the Rockefeller Institute, Alexis Carrel transplanted a kitten's lung into the neck of an adult cat. Of course, this was met with a mortality 2 days later, but this was the first instance of the thought process that there can be something done as far as lung transplantation is concerned. Almost, in the next 40 odd years, there were a lot of interspersed data coming from the world. All of it was obviously done on animals. This is Dr. Vladimir Demikov. He was very famous to do this head transplant in a dog. We can see in the photograph. Now, he followed this experiment with the first lung alone transplantation in a dog. This was in 1947, the year we got our independence. And later that year, he also tried a lobar transplantation in a dog. Unfortunately, the dog survived only for 10 days and there was bronchial disruption. Now, in a human, the first lung transplantation was actually attempted in 1963. This was in the United States of America and Mississippi, done by Dr. Hardy. This patient was actually a prisoner and he was suffering from COPD and had lung cancer. He survived only for 18 days. Now, after this, it was various groups all over the world which really took the game of lung transplantation forward. One of the notable ones was the Toronto group in Canada. Now, what is the story as far as India is concerned? Now, in India, you can see that 1947 and 50s and 60s was the time the world was, trying to do lung transplantation. In India, it actually boils down to the late 1990s when Professor Kane Cherian was the first one to do a heart and lung transplant in Chennai. So this was a heart lung transplant. We were in fact very fortunate to meet him personally in Ahmedabad 2 months back when he had come for the INSHLT. As far as only lungs are concerned, in 2012, there were 2 single lung transplants done. The first one in India was done by Dr. Madhushankar. This was done in Chennai. And the second one was done by Dr. Gyanesh Thakkar in Hinduja Hospital in Mumbai. This was the first lung transplant done on an Indian patient in India. Both of these were single lung transplants. Now, this is, of course, a graph. I've taken this from, one of the articles in which Unmil Shah is one of the co-authors. He's, of course, a part of our panelist today. This is an old data, but this just goes to show that the current scenario in India is, in fact, there's a lot of work which all of us need to do, because 140 crore population, certainly this few centers is not going to work. Now, what exactly do I mean by types of lung transplantation? Now, see, there are diagrammatically I have explained. Now, I just want everyone to pay attention to the third one, both lung transplants. Now, every single person thinks that lung transplant means by default, it means you're going to do both the lungs. It's actually the correct term is known as a bilateral sequential lung transplant. Of course, it is the most popular and the one which has got the maximum survival benefit to the patient. And I obviously showed the graph in which world over bilateral lung transplant is the most common. But in certain selective cases, especially non-suppurative lung diseases, even a single lung transplant can be performed it all depends on the patient's age, comorbidities, and the expertise and the experience of the transplant center. Now, pay special attention to the middle column, a lobar transplant. Remember, till now, lung transplant, we always need a cadaver. So we are dependent on donations. Now, living lobar lung transplants is a game changer. This was obviously first done in the US, and right now Japan is at the forefront in Tokyo, in which they are doing a lot of living lobar lung transplants. There's also a race in India as to perform the first living lobar lung transplants, and hopefully, if this is successful, this will obviously mitigate the need for organ donation. Now, what exactly are the indications and contraindications? I'll first be talking about the indications. Now, to be very honest, as I mentioned early on, every single chronic lung disease which is not responding to medical therapy is an indication for lung transplantation. The only thing what I have done is I've just categorized them as in various blocks. So the first block is obviously all your interstitial lung diseases. So your IPFs, your hypersensitive pneumonitis, your sarcoids, occupational lung diseases, histiocytosis, etc. The second, obviously, are the obstructive airway diseases. Now, obviously, all of us know in India, it's not the smoking related, but the non-smoking related COPDs, which is also a huge problem. And also, obviously, you've got the small airway diseases of various etiologies, alpha-1 antitrypsin deficiencies. Third is, of course, the pulmonary vascular diseases, pulmonary hypertensions, your connective tissue disease related pulmonary hypertensions, your Eisenmenger's, your CTEPH, and last, of course, are the chronic suppurative lung diseases. In India, the most common is bronchiectasis. We don't have a lot of cases of cystic fibrosis, but if you go to, let's say, if you go to UK, you go to Norway, you go to Canada, that is where you'll see a lot of lung transplants done for cystic fibrosis. Now, contraindications, as all of you all can see, it's a huge block. But believe me, it's just very simple for us to understand that if you've got any other end organ damage apart from the lung, you have to really be careful. So, for example, if suppose I'm talking about the kidneys, you can see the third block. If your GFR is less than 40, that is when, unless you're considering a multi-organ transplant, that will be a contraindication. Obviously, as far as the heart is concerned, if you've got an acute coronary syndrome or an MI within the 30 days, if you've got a stroke within 30 days, if you've got a septic shock, renal failure, acute liver failure, any active disseminated infection. See, in our country, for example, TB is a huge burden in our country. So, all of these are organ specific contraindications for lung transplantation. You've also got malignancies, you've got lack of patient acceptance or willingness, you've got psychiatric issues, you've got cognitive impairments, and obviously you've got patients who are still currently on substance abuse. So you've got active smokers, you've got people who are still on tobacco use. These are the people obviously who are contraindicated for lung transplantation. Now, this, according to me, is the most important concept which I want everyone to understand. What exactly do you mean by a transplant window? Now, I know that all my co-panelists are transplant pulmonologists, and one thing which all of us are really guilty about is whenever we get a patient, we always make the statement that you should have referred the patient earlier. Unfortunately, the word earlier is also a very relative term. So, for example, my early can be your late and your early can be my late. So, it's very important for everyone to understand what is a transplant window. It is the correct period for a referral to a lung transplantation service. There are two things which we must understand. First is the patient should be sick enough to need a lung transplantation, however, should be fit enough to tolerate the lung transplantation. I'm going to repeat the statement. The patient should be sick enough to need a lung transplantation, but should be fit enough to tolerate the lung transplantation. This is the subset of patients which actually we can put in the green window, which is what I refer as the transplant window. If the patient's condition unfortunately progresses too much, he will go on into the red triangle, which you see in the end. And at that time, it is too late. We can do a lung transplantation. However, results will not be as expected. Now, this is the last part of my talk in which I talk about the International Society of Heart and Lung Transplantation referral guidelines. Remember, I told that I will be talking about black and white data because the most common question which every single person has is when to refer. Now, this is an excellent document. I really request everyone to take some time out, go through this. This was a consensus document which was published in ISHLT in the year 2021, in which there is a proper black and white data in which every single disease, when are you supposed to refer a patient to a lung transplant center, and this has also got data for the transplant center as to when are you supposed to list the patient. Now I'm going to be talking about three diseases: ILD, COPD, and bronchiectasis, because these are the ones which we most commonly face in our country. So, first, lung transplantation should be considered when patients have got a high risk of death from the lung disease, ideally within 2 years if the transplant is not performed, and there is also a high likelihood of a 5-year post-transplant survival from a medical perspective. Now, let me talk about the first category, interstitial lung disease. Now, this is the referral criteria. When should a patient be referred to a lung transplant center? You can see the first point: whenever you're dealing with UIP, whether it is a histopathological UIP or a radiological evidence of a probable or definite UIP pattern. Second is when this is a spirometric data, when FVC is less than 80% or the DLC or less than 40%. Third is spirometric decline. If your patient in the last 2 years has got a relative decline of FVC more than equal to 10%, a relative decline in DLCO more than equal to 15%, or a relative decline in FVC more than equal to 5%, along with worsening respiratory symptoms or worsening radiology. Fourth is any use of oxygen, whether at rest or on exertion. Fifth is any inflammatory ILDs. This patient has to be referred early because this needs a detailed history, has to be looked into quite in detail. And last is any patients who are suffering with connective tissue diseases or familial pulmonary fibrosis. An early referral is needed because extra pulmonary manifestations will require special consideration. Now, as far as a transplant center, when are we supposed to list the patient? So first is spirometric value. If we've got an absolute decline in FVC more than 10%, or a decline in DLCO more than 10%, or a decline in FVC more than 5% with a radiographic progression. If a 6-minute walk distance, we are seeing that the patient is desaturating less than 88%, or there is a more than 50-meter decline in the past 6 months, any evidence of pulmonary hypertension. And fourth, if there is any hospitalization because of respiratory decline, pneumothorax, or an acute exacerbation. So this is actually for the transplant centers. Let me go to the next disease, which is COPD. When should a patient be referred? So if a board score is 5 to 6 with additional features which are present, for example, frequent exacerbators, increase in board score of more than 1 over the last 2 years, your pulmonary artery to aorta diameter more than 1 on CT scan, which is an indirect evidence of pulmonary hypertension, your FE1 should be 20 to 25% predicted. The second point is, despite maximal treatment, which obviously includes pulmonary rehabs, oxygen, despite all of this, if your patient is clinically deteriorating, you need to refer. Poor quality of life, which is unacceptable to the patient. And if a patient is a candidate for a surgical or a bronchoscopic lung volume reduction surgery, this is when the patient also needs to come to a transplant center. Now, what is the listing criteria? This is what we look into in our centers. Board scores of 7 to 10. Additional factors which include your further decrease in FE1 less than 20%, presence of moderate to severe pulmonary hypertensions, again, frequent exacerbators, or chronic hypercapnia. And the last disease which I would like to talk about is bronchiectasis. Now, remember, in the ISHLT, they have included CF and non-CF bronchiectasis to have the same referral. Okay, so there you don't have any different referral criteria for the two. So, the first is if FE1 is less than 30% in adults or less than 40% in children, or if the FEV1 is less than 40% in adults and any one of the following. So your 6-minute walk distance is less than 400, your PCO2 is more than 50, you have got an hypoxemia on rest or exertion, or you've got a pulmonary hypertension in which PA systolic is more than 50, you've got a worsening nutritional status despite supplementation, you've got 2 exacerbations per year which needs intravenous antibiotics, you've got massive hemoptysis requiring BAE, or you've got a pneumothorax. So if your patient has got an FEN less than 40% in any one of these, you need to refer. And the last 2 points are if your FE1 is less than 50% and your patient has got rapidly declining pulmonary functions. And last is any exacerbations which needs positive pressure ventilation. As far as the listing is concerned, if your FE1 is less than 25%, there is a rapid decline in lung function or progressive symptoms, frequent hospitalizations, particularly if in a year the hospitalization exceeds more than 28 days, any exacerbation needing mechanical ventilation, if your patient has got chronic respiratory failure with hypoxemia or hypercapnia, if your PA pressures are more than 50, on echo or evidence of RV dysfunction, worsening nutritional dysfunction, especially if your BMI is less than 18, recurrent massive hemoptysis despite performing a BAE, and last is if your patient has progressed into the WHO functional class 4. So these are the three most commonly referred diseases to all the lung transplant centers, and these are the referral and the listing criteria as far as these three diseases are concerned. So in summary, obviously lung transplantation is a definitive treatment goal for end-stage lung diseases. India 100% needs much more dedicated lung transplant centers to meet the ever-increasing burden of end-stage lung diseases. And last, and I cannot emphasize this point, early and timely referrals holds the key for a much better survival. Thank you so very much.
Thank you, Dr. Kapil, for this nice and lucid talk on the medical perspectives of lung transplantation, elaborating the nitty-gritties which every pulmonologist should know. Nextly, I would like to again invite all of the delegates for our NAPCON Pune, which is to be conducted on 23rd to 26th Jan 2025, and also invite all of you to participate and register for our ECMO and lung transplant workshop. I would like to invite our next speaker, Dr. Harshvardhan Puri. He's a senior consultant lung transplant and thoracic surgeon at Medanta Group of Hospitals, Delhi, with special interest in lung transplantation, tracheal surgeries, and minimally invasive thoracic surgery. Over to Dr. Harsh. Dr. Harsh, can you hear?
Just a second, I'll share my screen.
So before Dr. Harsh starts his talk, I would also take this opportunity to thank Cipla, who is our academic partner for today's webinar, and especially Harshal and team for an excellent job. We already have more than 1,300 logins tonight. So yeah, over to you, Dr. Harsh.
Thank you, Dr. Chetan and Dr. Umil, for that wonderful introduction. So where Dr. Kapil has stopped, we'll continue from there. I'm Dr. Harshvardhan. I'm a consultant in Medanta. And greetings to all the ICS members who have joined the webinar from Medanta Group of Hospitals and Institute of Chest Surgery and Lung Transplant at Medanta. So we'll break the whole thing into what is the process of lung transplantation after a patient is referred from our pulmonology colleagues to our center. So this photograph, it's a repetition from Dr. Kapil's slide. So I want to show you that in 2018, the data is around 17 and 18. India forms a very, very small part of this whole slide. These others, red, maybe we are somewhere very small. So I see this slide every day, every passing day, I see this slide, and I want a small purple dot or something like of India in this slide in the next 5 years. That is what makes us coming on this platform and showing our work to the people. So that this is a team which went to Toronto General Hospital for the training of lung transplantation, including pulmonologists and anesthetists, coordinators, and all those stuff. It takes a whole village to do a lung transplantation like surgery. So when we break the process of transplant, it is referral, it's evaluation, listing, recipient management, donor call, donor management, explantation, implantation, and post-operative care and follow-up. So whenever a patient of ILD, COPD, bronchiectasis is referred from a pulmonology colleague to our center, so we do a OPD consult, mostly because the patient is outstation patient, or even if the patient is in Delhi, we do an online evaluation of the patient and see his all records. This online evaluation is usually done by two people. One is a transplant pulmonologist, which in our case is Dr. Vivek Singh, and a transplant surgeon. And we divide the referrals between two categories: too sick to be taken for transplant if the patient merits evaluation, and the third is too good for the transplant. Patient can be continued on medical management as well as rehabilitative therapy for some time. And if we consider the patient to be merits evaluation, then the patient is brought to Medanta Hospital and admitted to Medanta Hospital, where an on-site evaluation of this patient, including around 40-50 tests, is done, where right heart catheterization, PET scan, and all the good advanced investigations are done to see whether this patient is fit for such a massive surgery or not. When this on-site evaluation is done, it is usually done in 4 to 5 days. The patient is discharged. After 2-3 days, a multidisciplinary team, which consists of surgeons, pulmonologists, coordinators, psychiatrists, everybody sits on a table, evaluates all the reports, and then we decide whether we are going ahead with the transplant of this patient or not. If it is a yes, then the patient is listed on NOTO, which is the national website for lung transplantation in India, and the patient family is counseled about the pros, cons, financials, everything. It's a 1.5 hour counseling with the patient is counseled, his IDs, etc. are taken, and he is listed on the NOTO website. After the patient has agreed and he or she is listed on the NOTO website, now starts the rehabilitation therapy by the transplant team, which includes online daily physio classes by our physiotherapists, on-site twice or once a week visit to the center, medical management by a pulmonologist, nutritional support by a dietitian, emotional supports. These people are emotionally very down. They need a lot of emotional upbringing, which is done by a psychiatrist, pulmonologist, us also. And the patient is advised to stay within the 100 kilometers of Medanta, which is very helpful when a donor calls come. This is one of our patients who is doing on-site physiotherapy on maybe 10 to 15 liters of oxygen. This is a patient of bilateral extensive bronchiectasis. So one fine day, when we get a donor call from NOTO that these kind of lungs are available in this center, we ask for details about because we want to match the donor details with the recipient details. These donors are usually in India are brain dead donors whose brains are not working, but their hearts are working. So we match these donor details with our recipient list. What we match is total lung capacity, volumetric matching if the CT scans are available, blood group matching, recipient's present condition and willingness to go for the transplant is rechecked. After that, a donor acceptance is done, and we connect. If the organ is allocated to Medanta, what we do is to coordinate with the donor hospital, and from this point starts the race against time. So you know this very famous picture of Sholay, that the team is divided between two parts. One is the donor team and one is the recipient team, and the process continues. Now, what the donor management team does, they contact the donor hospital and ask the ICU about the present condition of the recipient and starts taking interest in the donor care, which is optimizing the hemodynamics, even distributor of vasopressors, fluid management, antibiotics, thyronorm, optimal ventilation, lung protective ventilation, very important for donor management. And then the team starts its journey towards the donor hospital. We check the logistics. We plan our logistics to reach as early as possible. We sometimes use commercial flights, sometimes private jets. As soon as possible, we have to reach the donor hospital. And we have checklists for everything. Everything which we did in a donor hospital, from a small syringe to advanced products and everything, we take along with us from Medanta to the donor hospital. At the donor hospital, when we reach the donor hospital, we talk to the anesthetist or the critical care team taking care of the patient, and we ask for few And who consider of a donor team is a lung transplant surgeon, coordinator, and few techs also. So we check the history and all the documents of the donor. We check the gases, CT scans, and discussion happens with the lead anesthetist there. We do a bronchoscopy in bowel at that point. We take the bowel fluid mostly from the middle lobe, and then if everything is fine, the lung is accepted provisionally for the explantation. Whenever we enter the this OT complex, this is usually the scene in a donor OT complex, and there are 4 or 5 teams. One is the liver team, one is the cardiac team, heart team, lung team, cornea team, and all those stuff. Everybody is trying to take the organs from that body. So every time we stay there, I pray for a minute because of this soul who is giving life to at least 8 to 10 people in the country. So we always stay there. We pray for this noble soul, and then we start our the explantation surgery. The explantation surgery is done by sternotomy. First, the dissection of heart is done. Then the assessment of the lung is done. P by A ratio, etc., is calculated. Sometimes from the individual veins also. Then, if the lung is okay, if the P by ratio is good, then there are no nodules. Everything is physically checked. We start the process of explantation by giving pulmonplagia. That explantation of heart is done. Then explantation of lungs is done. The lungs are packed in a very special kind of a solution, which is known as Purpad Plus, and transported to the Medanta, the Medicity, in a very special kind of a fridge, which is a 10-degree fridge, which keeps the organ at 10 degrees, because there is a very good study done by Toronto General Hospital that when we preserve these organs on 10 degrees, they can be preserved for more than 10 to 12 hours. They have gone up to 36 hours. In Medanta, we are going up to 12 hours of ischemia time also. So return journey, you must have seen this or heard about this famous green corridor. We usually get these green corridors from the donor hospital to the airport, and from airport to Medanta, the Medicity. Lot of government machinery provides a lot of help for us reaching ASAP to the Medanta. This is a very emotional story. I want to just enumerate in 1 minute. When we went for a lung transplantation to Junagadh, I just wanted to show it here because I want to show that in India, surgeries are not technical, financial. They are very emotional kind of things. So you can see in the video, when we are coming out after taking the lungs in that go, and Dr. Arvind is talking to this person. This person is the husband of the girl who has donated her lungs for the. And when we were coming out, we were being showered by these flowers. Everybody was chanting these Bharat Mata Ki Jai, Bharat Mata Ki Jai. It was such an emotional experience. And this experience made me to write a whole story over this episode. I just wanted to tell that people say that donation is not possible in India. But this is not true. India is a very emotional country. We have to evoke emotions of the people to get more and more donations. So the team at Medanta, who is the other part of the team, starts the process of implantation surgery. Recipient surgery is done by a clamshell thoracotomy, bilateral dissection and preparation for bilateral pneumonectomy, initiation of a central VA ECMO. We are doing almost all the transplants on a VA ECMO. Recipient's pneumonectomy is done burst side first, but the timing of pneumonectomy is always done when the donor lungs are present inside the theater. So recipient pneumonectomy burst side first. A back table is done where the 2 lungs brought by us are separated into 2 parts. After that, implantation is done. It is done in the manner of bronchus first, PA, and then LA cuff. Reduction of the flow of the ECMO to half. Implantation of the other side, taking the patient off ECMO in most of the cases, if the PA pressures, etc., everything is normal, closure and shifting of the patient to ICU. After shifting of the patient to ICU, the patient is managed by the critical care team and the transplant team, and is extubated in next 3 or 4 days, depending upon the condition of the patient. And after extubation, these are the few pics of clamshell thoracotomy which we use for the transplantation. This is a central ECMO which is used for bilateral sequential transplantation. And this is a bronchial anastomosis, which we do first, then the pulmonary artery, and then the iliac anastomosis. And these are the criteria of taking of patient off ECMO, which is done in a very slow manner. The FiO2 is adjusted. If the patient is not coming out of ECMO, we go back to the 3 liter to 4 liter flow and exchange double lumen tube with single lumen, do a proper bronchoscopy, start nitric oxide against, and then beam. So when the patient is taken to ICU, a very aggressive physiotherapy regime, etc., is started on these patients, and they are managed properly. And 3 or 4 days after the ICU stay, they are extubated, and again the whole process of rehabilitation of their new lungs, new everything new is there inside their thoracic cavity. So they have to be taught to breathe again. This is a specimen pics of our first case, which were done for extensive bilateral extensive bronchiectasis. This is our second or third case we did on almost, he was ventilated on 100% of FiO2, and fortunately he got a lung in the evening and we could do it. So after the transplantation, see how our physiotherapist is again showing them, again teaching them, like a mother, she's teaching them how to breathe again. So this is the beauty of transplantation. It puts new life into your patients. So this is the first patient I showed to you, who was doing physiotherapy on 10 to 12 liters of oxygen, and now he's there in Kapurthala doing the same kind of physiotherapy without oxygen, enjoying his life and getting the taste of good oxygen, good breathing. So these are the results. Few patients with the team. These are the results, good results, which provoke us to do such prolonged 18-20 hour surgeries, and then also not feeling any tiredness. So I would like to show a small video at the end, which will show you the process of transplantation. So that how we do a donor lung retrieval. It's a very chaotic OT in the donor lung, but all's well that ends well. Reaching Medanta as soon as possible by a green corridor. We are very emotional people, always indebted to God to give us as much as possible so that we can give it back to our patients. Going to the implantation OT, starting the implantation process, doing the bend surgery, separating the lungs into two parts. Bronchial implantation, doing the pneumonectomy on the other side. And this is how these patients are extubated. When they extubate and breathe for the first time with the new lungs, it's something like a new life. So these are the results after a year of transplant. And all thanks to the our referring physicians for such a. So the problems of transplant are also there in India. The recipients are in millions, the donors are in hundreds, centers are in single digit, procedures are very complex, and medical issues are major. Cost is still a big issue. Pollution is a major killer. So we all have to work together to bring everybody on board so that the process of lung transplantation in India takes a front lead. So an appeal, let's come together, let's work for it, and thank you. Har jaan hai Anmol. Thanks a lot.
You will have to unmute Vimi.
Thanks, Dr. Harshvardhan, for the amazing talk. It is very important for all of them who is listening to understand the different medical and the surgical aspects of transplant, right from the initial referral and especially about what a transplant center really does. And everybody will be curious to understand what is a donor lung retrieval, how does it take place, and how will be the usual recovery. So it was elaborated in detail by both the speakers. Now, I think we have a lot of questions. So before that, I'll be introducing our panelists. So we have panelists from mostly all parts of the country. First is Dr. Unmil Shah. Dr. Unmil is a transplant pulmonologist who is working in HN Reliance and also in KIMS Secunderabad. He is part of a team who has done the first EVLP in India, and he is a chair for many international and national conference. Next is my colleague, Dr. Chetan Rao Vodapalli. Dr. Chetan is a interventional and transplant pulmonologist from Yashoda Hospitals, High Tech City. He has a great interest in intervention and has done a lot of research also in the lung transplantation. Next is Dr. Rahul. So Dr. Rahul is a transplant pulmonologist from from DY Patil, who was trained under in KIMS under Dr. Sandeep Attawar and Dr. Vijay Rahulan. He has been involved in multiple research projects in the field of lung transplantation and transplant immunology in India. So now we'll discuss the few concerning questions and the different questions from the audience. Over to you.
Okay. Thank you so much, Vimmi. And of course, let me also introduce Vimmi. Vimmi is also a budding transplant pulmonologist in Yashoda Hospital, Secunderabad, who's done his training from Belgium. And, he's the first transplant pulmonologist of our country to, in fact, have a paper on CLAD, in Lancet. This is the first public Lancet publication. So it was a very interesting presentation by Dr. Harshvardhan Puri Saab. So let us start with the panel discussion. I will first like to start with Unmil. Now, Unmil, of course, as far as India is concerned, you've got the maximum experience as far as transplants are concerned. Your team has been a part of more than 500 thoracic organ transplantation, which is a huge number. All of us look up to you, for data and for help and a lot of things. So, since yours was one of the first programs to be established in India, what were the budding problems which you faced?
Yeah. So the problems were at multiple levels. So one was at the recipient level, as you rightly mentioned, that when we started our program, most of the referrals were already in a delayed stage. They had already bypassed what is called as the transplant window, and we had to create awareness among our pulmonologist colleagues and explaining the criteria for referral, for listing. We used to always reinforce that referral does not mean listing. So that was one of the major challenges as far as the recipient side was concerned. Second challenge was at the donation side. Now, creating an awareness. Till the lung transplant program started in India, the transplant coordinators, the transplant counselors were all aware about, taking consents for kidney, liver, and heart, because there were more heart transplant centers across the country. So when the lung transplant program started, creating awareness among the community, among the grieving families about that, yes, lungs can also be donated, and also creating awareness among the ICU colleagues, the intensivists, about the donor lung management, because if we do not do adequate donor lung management, that becomes a foundation, the adequate donor lung management is a foundation for a successful outcome. So creating awareness, sharing the protocols about donor lung management across the ICUs. So that was again a challenge, and gradually over the period of time we have seen a standardized donor lung management going across. And the third was the finances, the challenges which the recipient families used to face because of the cost factor involved, the logistics involved, preparing the family, the patient, also mentally, psychologically, about understanding the concept of lung transplant. So I think the challenges were on multiple fronts. Setting the green corridors, the traffic police personnel were also not very much aware about how to go ahead. So explaining them about the shorter time, the estimate time, how fast can we reach. So there were the policy making also at the local OPOs about the lung transplant, and it's so there were challenges at multiple levels. But yes, I think we have come a long way, and I think now the protocols have been set and things are relatively easier.
Thank you so much for that, Unmil. We are, of course, looking up to a lot of things which you all have done, and we are always eager to learn from you. Chetan, I'll come to you now. Dr. Harshvardhan Puri had a very interesting point in one of his presentations. He said that the recipients are in millions in our country. Obviously, we are 140 crores. We've got a very high burden of chronic respiratory diseases. At your center, what is the proportion of different diseases which are referred to you? What will you give me the percentages as?
Yeah. So if you want me to answer in percentages, I can say that the major burden of referral diseases to our center is still ILD,
Okay.
which I guess is pretty much same across all the centers in the country and worldwide. It is also the same because people have moved away from transplanting COPDs to ILDs now, probably because of better management of COPD or better survival benefit of COPD with medical management. So as I said, we have a majority of ILDs. I can say probably 70% of the transplants that we have done are ILDs. The other 30% is majorly bronchiectasis, and that too post-tubercular bronchiectasis. We have done 3 cases of cystic fibrosis bronchiectasis, and after, at least with my experience, we have done only 1 case of COPD so far.
Okay. So I'd also like to ask the other transplant pulmonologists. So, I'll start with Rahul. Rahul, what is the proportion of referrals in your center?
So I'll agree with Chetan that most of them are ILDs only. In 70% of the cases, they are ILDs.
Okay.
COPDs are still rare. COPDs are still rare. But one more thing I would like to add is ARDS. So we are seeing a lot of ARDS cases also. Though they can be put on ECMO, and if they don't recover on ECMO, they can still be considered. If they go into a fibrotic stage, they can still be considered for lung transplantation as a bridge to lung transplantation.
Okay.
This is one of the indication which we usually forgot to mention, because many times we are seeing flu seasons, and we had seen COVID pandemic also. In those days also, there are a few patients who have been bridged on ECMO to lung transplantation.
Okay.
So this is one of the indication which we have to consider.
Perfect. Unmil, what about you at your center? Again, you agree with Chetan's statistics?
Yeah, I think, and we had published our data of 132 lung transplants in Lung India, where we had shown that almost around 80% were ILDs. And among ILDs also in India, the majority burden is taken by the chronic hypersensitivity pneumonitis, fibrotic, because that's the commonest ILD found as per the registry also, which came out, and followed by IPF. So I think the ILD takes a major chunk, followed by you can have IPH and bronchiectasis, which would trail behind.
Okay. Vimmi, I'll ask you the next question. See, I told you, we've got a very big country, 140 crores. I showed the map in which there are very few transplant centers. How do you deal with, let's say there is a certain physician who's let's say in Uttar Pradesh, and he wants to refer a patient to you, and you are in Hyderabad. So how do you deal with the logistics of such a referral?
So this is the common problem that happens in across the country, and as previous speakers and everybody said, there are only few centers that is doing a transplant. So usually when we get a call from a pulmonologist across any place, let's say in this case be Uttar Pradesh, always we have a video consultation, and to understand what is a pattern of the disease and how is the reports and what is the current condition and how sick the patient is. After that, we make sure that we modify or can we help the pulmonologist medically in some way or another. We see the reports and we try to tell over the consultation. After that, we have a discussion among our team and we make a call to bring the patient to our center so that we understand the risk and the benefit of lung transplantation. And so for that, these patients undergoes a set of tests like what Dr. Harshvardhan has said, so that we understand what are the concerning issues or what are the modifiable factors that can be optimized before transplant, or how risk a transplant can be, so that each the treating team and the patient's family and the patient is very clear about.
Okay.
And this is very important from a transplant point of view, especially for donor selection. What are the things that can be optimized? And this will really put a physio and all other modifiable things in place, and the enrollment in the program, and then the waiting time begins.
Got it. Okay. Rahul bhai, I'm going to ask you a very tricky question because this is especially seen in our countries. I think it is more unique to our country. Now, see, pre-transplant, obviously, that let's say there's a patient who's referred to you. Do you completely take over management of the patient, or do you think there is like a mixed jurisdictional management between you and the referral pulmonologist?
So, Kapil sir, I feel that in my case, I feel that it should be a collaborative effort with the primary physician. I usually involve the primary physician with this in the pre-transplant period as well as in the post-transplant period, because they are usually the first point of contact for these patients. And since they have been managing these patients for months or years, and they are well aware of their clinical behavior. So, may it be response to the antifibrotic agents, diuretics, anti-pulmonary hypertension medications. So they are well aware of their behavior to these medications. So whenever I am planning to change any medication, I usually consult them and keep them in the loop whenever I'm doing anything like this. But apart from that, our emphasis as a transplant pulmonologist is usually on the rehab part, pulmonary rehab part, which includes physiotherapy, or diet optimization, vaccine, multiple types of vaccinations, and all those things. That part usually I take care, and the immunological workup. So basically, the pre-transplant immunological workup and following up these immunological tests routinely. That is one of the part which I take care of. The rest of the things I'll manage in collaboration with the primary physicians.
So you feel that management of the end-stage lung disease you will leave to the referring pulmonologist?
It should be a collaborative.
The medical part.
Yeah, because they're managing the patient for a longer duration, and they are well aware of their behaviors.
Got it. Okay, Vimy, I just want to once again ask you, now you said that about these patients who are from far away, you do video consultations. Once your team deems fit, you will get this patient to your center. Once this patient comes to your center, how will you evaluate this patient?
So once the patient comes, we first of all have a physical meeting to understand how is their basic physiology, right from the body mass index, or how is their proximal or distal muscle weakness, or something from a medical point of view. So there are many connect CTD ILD where we can still give a try of with some medical optimization, especially before a transplant. So and the third important thing is, obviously when a patient comes, they usually enroll in our rehab program after our discussion with the team, so that we can understand that on oxygen they are able to do their regular activities, and how the weakness and other related issues can be optimized before transplant. And after that, this patient undergoes a set of investigation, like earlier mentioned, about the pre-transplant workup, right from the infectious part to the imaging of different areas like brain, paranasal sinus, chest, and the abdomen, to look for any primaries or other important manifestation which can be concerning. And other most important thing is the right heart catheterization and coronary angiogram for someone who is elderly, and RHC for everybody who is planned for a transplant. And the next most important thing is the immunology. So immunology, if you ask me, it is very vital before considering anyone, because it is a minute details of the immunology that is very important prior taking any donor organs and looking for any other rejection factors even after transplant. So once we do the investigation, we have a multidisciplinary meeting. We call these patients every 1 or 2 weeks to understand how is their progress from a rehab, how is their progress from a medical point of view. And it's a everyday or every weekly meeting that makes a lot of effort, so that patient is being motivated, the relatives are motivated, and the physio, we understand that is it on track or not on track. And thereafter it creates a lot of effort so that these things can be coordinated, and Thereafter, the patient undergoes transplant once there is a suitable donor is available.
Vimy, I just wanted to ask you, this entire list of pre-treatment evaluation, do you compulsory prefer it to be done only at your hospital, or do you give like a list of investigations to be done to the referral pulmonologist, let him do it at his place, and then you look at the reports? How do you prefer doing it?
So, as you said, it is not practically possible for every patient to come to our center. So, we tell the referring pulmonologist about the set of investigation that can be done there. However, there are few tests that we tell them it is better to be done in our center, but around 80 to 90% of the test can be done from their referring pulmonologist side, and we have a video consultation or a meeting after that.
Okay, perfect.
So in short, everyone need not come here to understand the risk benefit ratio of transplant to a transplant center. It can be done even at a referral center or at the referral pulmonology center also.
Got it. Dr. Harshvardhan Puri, you are the only surgeon in the panel. So, I'm going to ask you this question. I keep checking your profile. You are doing so much of outreach OPDs. I feel sometimes you surgeons are slowly, entering the pulmonologist domain also. So, do you think you are slowly becoming a physician also? You are incorporating that in your practice as well?
Sir, this question has specifically, it's for me because we are a very vibrant thoracic surgical unit. So most of these OPDs are thoracic surgical plus lung transplant.
Okay.
We have a very dedicated lung transplant pulmonologist, Dr. Vivek Singh, but we can't expect Dr. Vivek to be going from Kashmir to Kanyakumari to see all these patients. So yes, we have a very vibrant team of thoracic surgeons, like 7 of them. So we do these lot of outreach OPDs, but the exactly the follow-ups or a very specific thing is always done by Vivek. But yes, we all help him in this set. We see the follow-ups also with, as the doctor Sab has told, that with the referring physician, we keep a track of the follow-ups. How is the patient doing, etc. And whenever we are in that city, we see those follow-ups. And there is a very pertinent saying in surgery is, if you want to become a good surgeon, like if you want to become a good thoracic surgeon, you should know the respiratory sciences, medical part as good as a physician should know it.
You are threatening us, basically.
Helping you, sir, helping you.
Chalo, theek hai. Urmil bhai, now see, in my talk, I did speak about, the concept of transplant window for referral. For people who are joining in late, could you just explain what do you understand by the concept of transplant window?
Yeah, so transplant window is the phase, along the natural course of the disease where, the patient, if registered or listed for the transplant, and gets transplanted, would get the maximum benefit out of it. So doing too early, doing too late transplants are not going to be beneficial. The outcomes are going to be negative. So there are 4 indications of lung transplant, as we have seen, the 4 etiologies, whether you have a restrictive lung disease, ILD, whether you have a COPD, third is the pulmonary arterial hypertension, and fourth is the CF and non-CF bronchiectasis. So each and every etiology is going to have a separate transplant window. Some are going to have a broad transplant window, some are going to have a very narrow. For example, you have a progressive fibrotic ILD, IPF, past history of acute exacerbations, that recipient is going to have a very narrow transplant window. So catch early, register, optimize, and get transplanted. Vis-a-vis probably a patient of non-CF bronchiectasis who has been going on for years or months would have a slightly a broader transplant window. Also, patients of IPH, that's a very crucial cohort, because when you register a patient of IPH or when they get referred to you, it's very important that whether they have missed the bus, whether they were earlier a candidate for a bilateral lung transplant and now probably they are going for a combined heart lung. So I think a transplant window is a phase where along the course of the disease where each and every pulmonologist should look for specifically the criteria for listing, whether they are present or not. And that should be the phase where they should be listed for optimum outcome.
Okay. Chetan bhai, see, once the patient, let's say the patient meets the transplant window, the referral physician has referred this patient to you. But from a transplant perspective, what do you mean by pre-transplant optimization of this patient?
Okay. So I think when we talk about optimization, I can talk about it in 2 cohorts of patients. One is who is evaluated and found to be fit for transplant, but still you optimize for better survival or better outcomes. The other one is a cohort of patients who had some correctable factors in the evaluation, which you try to correct before listing him. So first talking about the second cohort, especially when you have a CTD ILD patients, you have to look at GE symptoms. And there are some ways to optimize their reflux before taking them to surgery, or have a plan of optimizing them intraoperatively. And the other side of it, you have evaluated a patient whom you have found fit to be actively listed, but you still have to optimize them before they get a surgery done. Like, especially when it comes, it is nutrition,
Okay.
optimize their BMIs, put them, enroll in them in a cardiopulmonary rehab program so that you improve their endurance, improve their muscle power and all. And you also give a set of vaccinations pre-transplant, because post-transplant, at least for a year, you will not be able to give them any live or live attenuated vaccines. So vaccination also plays a crucial role pre-transplant. And these are the major factors: nutrition, exercise, vaccination, and psychological support. Psychological support is always what inherent team in the transplant unit, and you should also take care of that. So
Okay.
this is the reason we ask the referral pulmonologist to refer them early, so that we have enough time to introduce the concept of transplant to the patient, and he or she understands it better before going for a transplant.
Okay. Now, Vimmi, because you and Chetan, both of you work in Yashoda, I just wanted to ask you this question. Now, see, in one of the points of optimization that Chetan mentioned was about rehabilitation. Now, even you have mentioned that you're enrolled this patient in a proper cardiopulmonary rehabilitation. Now this program in your centers is how long? That's my first question to you. And second is, do you prefer the patient every time to come to the hospital to do the rehab, or do you send your physiotherapist at home, or do you do something like an online rehabilitation? How do you do it at your center?
So I will tell the example of the patient whom before this meeting whom we have seen. So this is a patient of a connective tissue ILD who was having a progressive decline in lung function, and who was on around 5 to 6 liters of oxygen, but with a severe proximal and distal muscle weakness. So
Okay.
even a small effort in the walking, or his 6 minute walk distance is less than 100 meters. So we know that this is the patient who is physically deconditioned, and there are no more medical optimization. So first we always make sure that this patient we try to make sure whether he can undergo a 6 minute walk test to understand the basic or the baseline 6 minute walk distance.
Okay.
And we have a set of protocol or a pro forma where we grade the each muscle power into different grades based on their weakness, etc. And we inform our physiotherapists that this is the different problems that we have encountered in the OPD visit. And we would like to optimize either in the endurance or the different weight training exercises, and to do different sets of exercises on oxygen. Once we inform the physiotherapist, they also have the first visit in the hospital, and we tell them that it is advisable to come thrice weekly to hospital, but it is very difficult for a patient to come with an big oxygen cylinder, and I mean, coming from the home in an ambulance or an auto is difficult. So we make sure that we have a rehab physiotherapist who regularly visits their home almost daily or at least thrice a week, and they will be in constant touch with us about the different assessment and the different response after 2 or 3 days, or at the end of the week they inform us with their assessment, and we see the patient every 2 weeks in our OPD, so that it goes as a coordinated and a systematic pathway, so that we can assess how is their physical condition, or from a rehab point of view. We can assess how is their emotional support from the other relatives during this time. And rehab program, we usually make sure that the moment they enroll, it goes as a strict and a coordinated way till they get a donor. There are some times where we tell them before this rehab program is optimized, only we will consider this patient for the transplant. So there are different sets that we usually we try to tell, but rehab is very core or the vital before the transplant.
Perfect. But Vimi, when patients are really on high oxygen support, don't you think it's medico legally also safe to get the patients every time to the hospital so that in case of any untoward incident, obviously you've got an ICU ready?
Yeah, I think it is important, but most of the problem what happens is the financial aspect of getting admitted and doing the physio from that aspect. So we make sure that once the patient is stable, then only we make sure that the patient goes home, or we make sure that they have a home care nurse, and we make sure that oxygen or the other BiPAP or other settings are arranged at home, and they have someone to take care of these oxygen and other aspect and the medical part, so that, and they keep in touch with us so that we train our physiotherapist and the home nurse whoever is there to understand how is their condition, and then we take the further call on the weekly visit.
Okay.
Yeah. So to continue to this, as he rightly said, we select a stable cohort of patients who can be rehabilitated at home.
Okay.
The otherwise sick lot, we definitely not do at home. The other concern I have in calling them frequently to hospital is infections. They are severely immunocompromised, and every visit to the hospital will add a risk of infection because it is a common utility, and you usually do not have separate sections for the transplant people or pre-transplant people. So that's one major concern I look at.
Okay, correct. Now, Rahul Bhai, see, Unmil, in his last answer mentioned this, especially in some diseases. He mentioned about IPH, but I'm talking about all diseases. What happens is, suppose there's a late referral, all of us know hypoxic patients, there is development of pulmonary hypertension. It will slowly start affecting the right side of the heart. We've seen this time and again. Once this patient comes to you, chronic lung disease with affection of the right heart, how does the team select between only doing a bilateral sequential lung transplant versus a heart and lung transplantation?
So if we see the worldwide data nowadays, the number of combined heart lung transplants or indications to go for a combined heart lung transplants are going down. That is one because availability of extracorporeal life support, that ECMO, intra-op and the post-op period, because of which, even if the patient has a primary or a secondary pulmonary hypertension, though it is severe pulmonary hypertension, or though we feel that on echo or on right heart study, we feel that it's a severe RV dysfunction. In such cases, what we prefer to do is we do a cardiac MRI where we can assess the RV ejection fraction, where if the RV ejection fraction is going below 20%, that is an absolute indication to go for a combined heart lung transplant. Otherwise, those who have a severe pulmonary hypertension with RV dysfunction but RV ejection fraction more than 20%, we still prefer to go for a double lung transplant rather than going for a combined heart lung. So that will the other point in doing a double lung transplant with a risk of patient going on to a post-op ECMO is because availability of organs. So getting a combined heart and lung together is very difficult because the criteria for to get a standard donor criteria lung as well as heart together is very difficult nowadays. What we see, so the waiting period for a combined heart lung transplant would go around for somewhere around 1 year to 2 years also.
Okay.
Compared to a double lung transplant. So we prefer to do it a double lung transplant rather than a combined heart lung transplant unless there is a severe RV dysfunction, which will be proven by a cardiac MRI. Yes.
Cardiac MRI, got it. So cardiac MRI is quite essential in evaluating. Okay.
Yes. And
Chetan,
apart from this, the other absolute indications to go for a combined heart lung transplant would be irreparable congenital heart disease with a Eisenmenger migration, and terminal lung disease with a unfortunate severe LV dysfunction with the poor LV function. We are left with no other option. We have to go for a combined heart lung transplant.
Okay. Chetan Bhai, I just want to ask you this. Now, how do you treat extremes of BMI? See, we know that majority of the lung disease patients, unfortunately, have lost a lot of muscle mass. They are completely debilitated, chronically. Now, Vimy did mention about how each muscle is taken care of in the rehab. But I want to ask you with low BMI and also the opposite. Suppose a patient is Cushingoid in front of you. How do you deal with these extremes of BMI?
Yeah. So as you mentioned, if you look at the ISHLT guidelines in the consensus statement, they have a mention on BMI. though it is not an absolute contraindication, but it is a relative contraindication that is associated with high risk when a BMI is less than 16 or more than 35. And they recommend that only centers with experience to take up these cases.
Right.
Like you likely said, and when we talk about our indications, we see a lot of non-cystic fibrosis bronchiectasis who are majorly below that acceptable BMI range. And also in the cases that are referred to late, they have a lot of cachexia and muscle wasting and low BMI. So what we try to do is, obviously, first thing is to improve their oral diet, take the help of a dietitian, calculate their calorie intake, protein intake, and do. And most of the times, these people still don't cope up with it because of that high catabolism. And even while eating, they would not be able to eat well because of the oxygen support simultaneously going in, and they have this aerophagia. So for people who fail to cope up with building up mass, what we can do is either start a Riles tube feeding, or in the worst case, you can even do a peg tube feeding.
Okay.
So patient will take orally as and when he requires, and the extra supplements can be driven through the RT or peg feed to optimize their BMI. On the other hand, on the other extreme, if the patient is more than 35, at least in my center, I would definitely not take up the case straight away for a transplant, because literature says any obese patient has a high mortality and their chances of PGD are high for reasons unknown. You can still manage underweight patient, but managing an overweight patient is very difficult. Intraoperatively and postoperatively rehabilitating them is also difficult. And we all know that the key to successful transplant is early mobilization after the transplant, which becomes very difficult when they are in the obese category.
Perfect.
So when a patient who is obese, again, enroll in them in your rehabilitation program, try to cut down on their diet, increase their exercise, or maybe now you have this medical management where they can lose weight. Also, we have tried that in one patient and I'm successful. Patient lost 9 kgs in 3 months, so we listed her semaglutide.
So shall I start it, Chetan?
No, you're not listed yet.
Chalo, theek hai. Chalo, if you're talking about extremes of BMI, I want to get Harsh Bhai into this because, now BMI is different. Obviously, since the BMI of the patient will change, the thoracic cage will change, the size of the lungs will change. So, Dr. Harshvardhan, as a surgeon, what are your methods of size matching for the lungs of the donor and the recipient?
So usually, what we have at practically when a donor call comes is a X-ray, and we ask for the height of the donor as well as we have the height of the recipient to be by a set formula. We calculate the predicted TLC, and then we take it to a standard deviation of -20 and +20. So for COPD cases, 20% above, we can go up to 20% above of the PTLC value because their thoracic cage is to a it's more distended than normal population. And in an ILD case, because of the that fibrotic component, their thoracic cage is on a lower, so we go for less to -20 of the standard deviation. So this way we can calculate if it's a in-house donor, we have a good CT scan available. We do a volumetric matching also. Sometimes we are fortunate enough to get these CT scans from good CT scans from donor hospital also. So this is the way we match the size of the individual.
Okay.
And ultimate that testing of the size is always done on the table. When we initially put the inflated lung, we make the lung block, we just take the lung, we stand there because the cavity is totally open. We see how much chopping, etc. we have to do. And when we fit those lungs and the anesthetist gives the first blow of breath, we see if we are overboard and maybe some chopping here and there helps at the end also. And there is a whole big mechanism if there is a big size mismatch. But usually what we do is this.
Okay, got it. Now, Urmil, I'd like to ask you, now this is obviously a non-clinical question, but I feel in our country it's a very important question, and that is the financial burden of lung transplantation. So, could you just tell all the listeners and all the viewers, what exactly are the financial burdens of lung transplantation, and at your center, what steps do you take to mitigate it?
Yeah, so I think, as you rightly pointed out, that financial burden is crucial as far as our settings are concerned, and it starts the moment the patient gets listed, because a lot of effort goes into optimizing and rehabilitating the recipient. As soon as the patient gets transplanted, the post-operative period. Now there are every program has a particular package where you would try to help the patient as much as possible in the immediate or the acute post-operative period. But once the patient gets discharged from the hospital, the financial burden doesn't stop there. It just continues, because you have to do multiple blood tests. You have to keep monitoring the tacrolimus levels almost frequently in a week. There are various other blood tests to be done. There are almost 15-20 medications, which includes right from immunosuppression to antibiotic prophylaxis to antifungal prophylaxis and other rest of the medications, which add to the monthly cost. Plus, there are surveillance lung biopsies. In between, there are check bronchoscopies done where the patients have to come to the hospital. God forbid if there are any complications which patients develop, whether it is rejection or infection, and that comes with its own package of financial burden. So I think the patient, that is why I think the most important way to mitigate is one of the most important ways would be to refer early, because when you refer early a patient, the patient is on the waiting list, the family gets time to optimize not only the physical condition of the patient, the mental condition, but also the financial support. They have time enough to apply. There are various NGOs, trusts. There are a few states have CM funds. PM funds are also available, where it takes time to apply and get the approval. So I think referring early gives enough adequate time for the family to optimize for the financial, give them a rough estimate about how much it is going to be, plus minus. And specifically in Mumbai, there are many NGOs, trusts, which do definitely help, for the patients specifically. So I think this is the way ahead, where the patient family can benefit by proper planning.
Okay, so I mean, let's now move forward to the donor calls. So Chetan, I'll first ask you. So you've obviously got your listings, you've optimized your patient, and now there's a donor which is available. Now, as a transplant team, once a donor is available, what all are the things which you look for in a donor?
So as we talk, the phone that I answered right now was a donor call. So I was
unmuted that, so that all of us could have heard your step.
But everyone doesn't understand Telugu, right?
Got it.
Yeah. So as soon as we receive a donor call, the first thing I asked him was about the height, weight. Obviously, that is how we match it with the recipient. Probably either with your predicted TLC ratios or with a gross height measurement, especially if it is a male to male. But that doesn't always fit when it is from a female to male or male to female. So if you look at a PTCLC predicted TLC ratio, we somewhere go between 90% to 120%. Keeping height weight aside, obviously, first thing is you look at the group if it is a match or not. Second thing, you look at the radiology. Ideally, as per the ideal donor criteria, you should have a clear radiograph without any patches on it. Then you look for a little bit of history and when is the patient ventilated, how long is she or he on a ventilator. Then you look at the gases. For an ideal donor, a PF ratio should be more than 300 at least to accept them. And then you also, if it is a male, you try and get the smoking history, which should be less than 20 pack years. But unfortunately, we don't get that very often in Indian scenario because most of them don't give it right. And to some extent, you might have to rely on your inspection when you go for a on-table inspection. So at least the basic thing is height, weight, obviously the blood group. Then I'll have a smoking history if possible, date of ventilation, and if there are any culture reports of the donor that are available, if it is quite some time, a clear X-ray and blood gases for me to start off with. Then if I am on priority, I'll choose my recipient. If it is a match, then we go for, as a pulmonologist, my duty is to go for a bronch, see how the bronch is. Ideally, it should be very clear. Or even if there are some central airway secretions, we are not much bothered. We are more bothered about peripheral secretions. And if there are some peripheral purulent secretions or mucopurulent secretions, you suck them out and check for repooling. If they are repooling, then it is a red flag for me. If there is no repooling, I would still proceed for surgical inspection and take a call.
Okay. But Chetan, if you've got a chest X-ray which is clear, do you press for the CT or you're okay with the X-ray?
So we have been there, we've done that, we've burnt our hands. CT has been we've been over enthusiastic, but X-ray should be a decent option, is what we understood.
Okay, so good X-ray with a good PF ratio, you're happy. Okay, perfect.
Yes.
Now, Vimy, in explaining the budding steps, Unmil mentioned about this, that donor management is of really a lot of importance, but it's often underlooked, But if you could just explain very simply what all are the steps that we must look for as far as the donor lung management is concerned.
So this is the common problem that any transplant team has. That is, when there is a brain dead stage happens, there is always two stages that happens. One, there is a stage where there is an autonomic storm, and there is a stage when there is a loss of brainstem reflex. So when you have an autonomic storm, you have a hypertension, or you have high BP, you have tachycardia. And when there is a loss of brainstem reflexes, you have a hypotension and other hemodynamic instability. So this is a time where we should cautiously give fluid, and we should make sure that we give the right inotropes like noradrenaline or a vasopressin to make sure that perfusion is adequate without overflooding the lungs, because overflooded lungs, or a lungs that is being in on a flooded state, it really impacts from a surgeon points of view, especially with regard to the compliance, and especially with regard to the lung sizing, etc. Second most important thing is the lung ventilation settings. So usually we see that the lungs are ventilated with a very high PEEP or very high FiO2, and this that is hampering the peak pressure. So we make sure that it is ventilated at a 6 to 8 ml of tidal volume per kilogram, or the PEEP that is adequate, with making sure that the peak pressures are okay, or it's less than 30. So these are the two most important thing, especially one is related to the fluids, and second important thing is related to the ventilatory setting. That is very crucial, especially from a transplant team point of view. And it is always essential, or it's always vital to speak to the intensivist before going to the donor lung retrieval or a bronchoscopy, to make sure that these things are being performed there. But I think we always make, or we have a protocol for a donor lung management in our center, so that the kidney and the liver and the heart and lung transplant team have a general consensus, so that this each donor is being taken care from all point of view.
So, Vimy, this ventilatory management and all, is it the transplant pulmonologist who will take over management, or is it the cardiac anesthesiologist who will look into this?
So it is the cardiac anesthesiologist that looks into it, but we make sure that we'll be the first point of contact at the donor, especially for a bronchoscopy. So we usually inform them these are our recommendation and from our transplant team, and they try to improvise that.
Okay. Now, since you mentioned bronchoscopy, Rahul bhai, I would like to ask you this. Now, I know that Chetan did, mention about bronchoscopy, but I want to ask you, what is the role of bronchoscopy during retrieval of the lungs?
So again, bronchoscopy is a very important tool, even if the bronchoscopy is done in the earlier stage by the donor hospital. But many times the patient might have developed VAP or something, some aspirations, maybe due to RTAs, or maybe due to during ventilation. So for such cases, I prefer to do a on-table bronch also. So where I can confirm any aspiration, whether there is a significant aspiration, or as sir mentioned that whether there is a repooling, which is an indicator. Most of the time, we don't get the cultures, we don't get the tracheal secretion, endotracheal secretions, or the BAL. So in such cases, which is the ideal case scenario where we know the cultures, but most of the time we don't get it. So in such cases, we prefer to see for repooling. If there is a repooling, that is an indication of a consolidation or an active infection, which we can decline such organs in such case scenarios. Apart from this, many times we see that there is fluctuation in the PF ratios. Sometimes the PF ratios are given good, and towards the prior to the retrievals, they usually dip. And most of the time, as Vimy mentioned, that some centers try to flood them for the kidneys. They try to give a lot of fluids, And in such cases, if the drop in PF ratio is just because of the flooding, if it is not related to infection, we can still consider. If we see that there is pulmonary edema on bronchoscopy, so we can still consider such lungs even with a low PF ratio. And we have seen such cases being taken, and they are doing good. So
But
on
do you
yes.
do you prefer the transplant pulmonologist to go and do the bronchoscopy in
Yes,
retrievals,
yes.
or like how Medanta does it? The surgeon do it?
So no, I prefer to do it myself
Okay.
whenever possible. Whenever possible, if it is not possible, few of our surgeons also do it, but
Okay.
I prefer to do it myself again.
Perfect. Dr. Harshvardhan, now in your talk, you did show us that representation. You had that ice box, sort of in which you were transporting the lungs. So that just led to a lot of questions. So usually we've got this concept of an ischemia time. So could you explain what is the meaning of warm ischemia, what is cold ischemia, and when you're finally transplanting lungs, what is the total duration of the surgery?
So usually, what conventional teaching is that when we cross-clamp the aorta, from that time to the time we take out the organ from the body and put it in those bags. This is the warm ischemia one. And from the time we transport the organ from the donor hospital to the recipient hospital, and we take out the lung for the first implantation, then it is the warm ischemia time starts from that time. And when we put those the first lung inside and we give a reperfusion, so this is also an ischemia time. And the second lung is again put into the that fridge or whatever everybody is using. That is a cold ischemia time of the second lung. And then the second lung is taken out. It is the bronchus is sealed and the perfusion starts. It's also is ischemia too. So everything included in this whole thing is the ischemia time. So the conventional teaching is that this ischemia time should be between 6 to 8 hours if you
Okay.
want to avoid a PGD in these patients, usual PG. But what Shaf Keshavji of Toronto General Hospital did a study in around 24 years back on pig models, 17 years back, sorry. So, and concluded, made a hypothesis that if we preserve these organs on different temperatures, maybe the results of this ischemia times or PGD in these patients can be reverted back. So they did it on different temperatures, and what he found was 10 degrees to be a very good temperature. So they again did this study a few years back and made this prototype which can maintain the organ temperature from 8 degrees to 12 degrees. So an average temperature of 10 degrees. And when we put this organ inside the Perfadex bag, inside this, so average temperature of 10 degrees is maintained. And their hypothesis is that you can preserve these organs or the ischemia time can be extended up to 12, 18 hours, 36 hours. We have gone up to 36 hours, but in Medanta, we haven't gone more than 13 hours. Our highest ischemia time is 13 hours, and the patient has grade 1 PGD on post-op day 1. So we are extending our barriers. The whole point and gamut is that this surgery should be done in a manner that it can be done as an elective surgery, not an emergency surgery. There are a lot of studies to show that if we do these surgeries as elective surgeries, maybe start at 6 a.m. in the morning, the whole team is fresh, the surgical team is fresh, everybody is fresh, and the results are better. One point is that, and avoiding these PGD, ischemia-based PGD injuries in these patients. These are the two major points where these all temperature-based studies are being done. And we are fortunate enough to have this bridge with us, and we are experimenting with our ischemia time because of this bridge.
Okay. Unmil Bhai, I'd like to ask you this question. Now, see, Dr. Harshvardhan did mention about PGDs. Now this is something which we exclusively see in the first, 3 days after lung transplantation. Now, I personally feel that the post-operative management of lung transplant is as important as the surgery. So, if you could just tell the audience a few salient features of post-operative management.
Yeah. So I think the post-operative management begins right from the OT, after the implant, when the chest closure time is there to decide whether the surgeon is going to close the chest on that day of transplant, or whether we are going to wait for the next 24 to 48 hours, let the edema swelling settle down, and then we close the chest. Also, it depends upon the post-implant gases, whether the patient is going to require any post-operative support in terms of ECMO, or whether the gases are good enough to go ahead directly into the ICU. Once the patient lands up in ICU, I think the most important thing is starting with the immunosuppression, maintaining a protective ventilation strategy, starting with the feeds as the patient becomes awake, and the sedation is minimized. Minimizing sedation is very important to understand the neurological assessment of the patient post-operative. Try to, if the gases are good, then probably in the next 1 or 2 days patient can be extubated. If we feel that the patient cannot be extubated, patient has a severe PGD or moderate severe PGD, then go for an early tracheostomy. That helps in better toileting. Start with the bronchoscopic assessment early in the post-operative period as well, to look for the anastomosis healing, to go for the multiple samples of lavages to rule out infections. By the time we have the donor cultures available to guide us for the antibiotic, we start with the basic antibiotic on the day of surgery, POD 0, and then the donor cultures would guide us about whether upgrading the antibiotics or not. Also, once the immunosuppression starts, start monitoring the levels of tacrolimus, and also that would guide us about how to optimize, because the TAC levels cannot be too high or too low, because that can have a hit on the, specifically the high levels can have a hit on the kidneys, and that's very important in the early acute post-operative period. And also introduce antibiotic antifungal prophylaxis, also introduce sequentially the PJP prophylaxis. So I think it's a well protocolized post-operative management which goes through. Also involve physiotherapy early on, because that's a crucial out of bed mobilization once the patient is extubated, and also optimize the nutrition.
Unmil bhai, do you think that the post-operative management should be the transplant pulmonologist domain or the intensivist?
So I think it's a joint effort, but definitely I think the transplant pulmonologist can always guide the intensive colleagues about how to go ahead, as far as the various aspects of the lung, aspects are concerned. But I think, yes, it's a joint effort. It's a teamwork ultimately.
Okay, perfect. Now, Chetan, I'm going to ask you the most common question, because this is often asked not only by the referring pulmonologist, but even by the patients. And everyone always asks, what is the success rate of lung transplantation? So how will you tackle this?
Okay. So if we talk about the survival data worldwide, all the major reports say that 1 year survival is somewhere around 80 to 90%.
Okay.
And 5 year survival is 60 to 70%. And there are some centers which claim even more. Now, because this is a pooled up data, you have to include all the centers' experience. Some are very well experienced, some are non-experienced. So the pooled up data is 1 year survival is 80 to 90%, and 5 year survival is 60 to 70%. The average lifespan after a lung transplant is somewhere calculated to be 5.2 years.
Okay.
But keeping this aside, when we actually talk about success or survival of a lung transplant, one thing I explain my recipients at the time of counseling or my referral doctors is, when we do a lung transplant, we look at more of quality of life benefit than survival benefit, which has to be emphasized, and they tend to understand that.
Okay. Okay. Now, the quality of life, I mean, since you've introduced this concept with me, I'd like to ask you, now, many people think that once I've got a lung transplant and that's it. The very fact that they are on lifelong immunosuppression also is something which we have to emphasize, because they think that once the transplant is done, that's it, I am free. But what do you counsel, if Chetan talks about quality of life, do these people need to make some lifestyle modifications lifelong?
So the important thing what post-transplant patients forgets is once they are very fine in their physical mobility, or once they go back home, most of them do stop medication, do visit the general crowd, and do take the foods frequently from outside. And we see them coming back with a different issue. So we have lost a patient who has stopped the medications when he comes for a follow-up, when his serial tacrolimus level was 1 and 2. Retrospectively, we found that even the family member and the patient is being taking some medication where it is not tacrolimus. So we have different problems of post-transplant. So what we usually tell them is we give them a diary or we give them a protocol and make sure first the family and the relative is being taught how to take the medication, number one. And second thing is that we teach them about how to monitor the lung function daily from their home and what are the different things. So we always tell them to do the home FE1 monitoring and the peak expiratory flow. And we tell them how to monitor in the morning, that 3 readings in the morning and 3 readings in the evening, so that we know that serial drop in the FE1. Second thing is that, as Dr. Unmil said, all these patients are on steroids and different immunosuppressant medication. So serial monitoring of their blood sugar and the other renal dysfunction is very vital. So we make sure that even if they go back home, they have a monthly or based on their post-transplant month, they have a serial follow-up with the different sets of investigations so that they are being monitored. Fourth thing is that we tell them after about 6 months to 1 year, they can do their regular work, but with a COVID protocol ahead. That means they have to wear a mask and try not to go to a scenario where which is overcrowded and you feel there is an exposure. Other most important thing is these are the patients who forget to tell even if there is a small fever, and they usually inform when there is a serially when there is other problems of fever with worsening cough or they have a low desaturation. So we always tell them, if you have a concern of a fever or a worsening cough, or you feel that you feel more breathless, or the reading in the daily FE1 monitoring is dropping, please inform us.
Okay. Okay. Rahul bhai, again, I'll put you on the spot. I did ask you about the mixed jurisdiction before the transplant. Now I am fast forwarding to the period post transplant. Okay. Now, suppose your patient is being discharged from your center successfully. Now, post operative follow up, do you exclusively do it, or again, do you believe that it should be a mixed sort of a follow up between you and the referral pulmonologist?
So I would divide it into two parts. Like initial 3 months post transplant, we prefer, even if the patient is from outstation or some other state also. So we ask them to stay in the same center, nearby to the center, and they can follow up with us regularly. In initial period, the follow ups like daily FEN monitoring, daily vitals monitoring can be done through WhatsApp groups. But other things like bronchoscopies, serial bronchoscopies, surveillance biopsies, which we usually do on first month and 3 month biopsy, as a surveillance biopsy, we usually prefer to do it ourselves. And along with this, once the patient go out of station, they can visit us every 3 months. And in between, if required, they can visit the primary physician also. But that the management would be again in collaboration with the transplant team, because any change in medication should be decided by the transplant team. That is what I prefer.
Okay, so you prefer 3 months, at least a patient has to compulsorily be in Pune and be following up with you. Okay, perfect. Yes. Urmil bhai, you did mention about surveillance bronchoscopies, and even Rahul did mention. Now, if I ask you a very broad question, what is your take? What is your viewpoint on post-transplant bronchoscopies?
So post-transplant bronchoscopy is, it depends upon whether we are doing it in the early recovery phase where the patient is still in the hospital, where we, as I mentioned earlier, also we keep monitoring the healing of the anastomosis. We keep doing the lavages serially to make sure that there is no infection. And also it helps us, get an idea. Initially, there is a lot of sloughing, so that requires a lot of toileting to be done vigorously. Once the patient is discharged, as Rahul mentioned, there are serial, transbronchial lung biopsies which have to be performed within 1 year. So most of the transplant centers have a protocol of 1, 3, 6, 9 months is plus minus, and 12 months, which is the 1 year biopsy. And after that, it would depend upon center to center whether they would do it or not, or whether they would go for other non-invasive markers for monitoring the rejection. So the transbronchial lung biopsies are very crucial because they help us get an idea about, whether any occult rejection or whether there is any asymptomatic signs of rejection happening or not. And also if there are any shadows on the CT scan, that it guides us about doing a biopsy where you can pick up whether it is a rejection or infection. Along with the lavages, what we do. So I think the transbronchial lung biopsies play a very important role, predominantly to monitor the incidence and prevalence of rejection. And also the response. If there is a rejection diagnosed on a histopathology and you have treated that rejection, you would definitely repeat a lung biopsy again to know whether the rejection has been treated completely or whether there is any progression.
But Unmil bhai, I want to ask your opinion. Do you believe in surveillance or do you believe in CFDNA monitoring and then deciding about the bronchoscopy?
So what we have incorporated in our protocol is that we do cell-free DNAs or donor-derived cell-free DNAs as a part of a pre-biopsy protocol. But as of now, we still believe in surveillance lung biopsies for at least a year, so that's why we keep doing it as and when. And also it depends upon the condition of the patient. Sometimes the patient is not discharged at 1 month, so by the time the patient goes home, gets optimized, it's probably second month, and then we do the first biopsy. So I think the recovery phase also would define, how frequently are going to do the biopsies. But yes, I mean, we still go ahead with the surveillance biopsies at least for the first year. After the first year, definitely we would go by the cell-free DNAs, the clinical radiological correlations, and in some patients we definitely do it 6 monthly for the next 1 year.
Okay. Dr. Harshvardhan, I did ask Rahul about this decision of double lung versus heart lung. Now, I want a surgical viewpoint about this, single lung versus bilateral sequential lung versus heart lung. What will you tell?
Sir, in India, most of the indications go for a double lung transplantation. Now, the statement I'm making because, see, you can do a single lung transplantation in ILD, in COPD also. But the point is that those patients should not have developed pulmonary arterial hypertension. So practically, we see no scenarios in India like that. The other problem is suppurative lung disease. It has to go for a bilateral sequential lung transplant. 2 indications. Now, coming to heart lung transplantation. So, very few indications are left, Eisenmenger syndrome. And getting a heart lung block from NOTO as such has become very difficult.
Okay.
And by keeping these patients on maybe preoperative ECMO or postoperative ECMO for a few days, this right ventricular failure can be tackled. So I still think that even in severe PH, the double lung transplantation is a preferred method, and very specific indications for going for a heart lung transplantation. Like VSD was considered as a indication to go for a heart lung transplantation. But people are in advanced centers, in good centers, are doing VSD closure and a double lung transplantation and taking the patients out very meticulously. So most of the indications in the country are for double lung transplantation at the moment. Very few for single lung, and the ratio of heart lung transplant is also decreasing slowly.
Okay. Unmil bhai, you didn't mention in your previous talk also, but the dreaded word after any organ transplantation is rejection. The patients perceive it, it's almost like a failure, and they feel that they're about to die when you use the word rejection. So for the audience, could you explain what is rejection and what are the types of rejection specifically after lung transplantation?
Right. So usually when the patients, as you mentioned, when they come for opinion for lung transplant also, one of the commonest questions is, would the lung reject, after the transplant, because they would like to know it upfront, So we always explain that the rejections predominantly are divided into acute and chronic. The acute rejections are of 2 types, basically. One is an acute cellular mediated, which is T cell mediated, ACR, which we call as, and other is AMR, which is antibody mediated or humoral response. As per the ISHLD registry data, almost 20 to 30% of the recipients would get some or the other form of rejection in the 1 year post-transplant, and that's quite common. And usually I assure patients that most of these rejections are treatable. There are better medications available and no need to worry about it. the textbook the textbook type which is mentioned as hyperacute, we don't see nowadays, because with better induction strategies available and better medications available and better evaluation of the recipients, we know who are sensitized and who are not sensitized. So I think predominantly the acute rejections classify into either cellular mediated or humoral mediated. Any episode of acute rejection can predispose to what is called as chronic rejection, or what is called as chronic lung allograft dysfunction, which can happen as early as 6 months post transplant and can go on for years together. Now, the ISHLD registry data shows that at least at 5 years, 50% of the recipients can or at the risk of developing clad or chronic rejection. So this is something which is very important. There are various risk factors which can predispose to chronic rejection, which I would not go into it right now. But chronic rejection or clad are also of two types predominantly, but there are other two phenotypes also. So one is, for a broader simplified version, obstructive and restrictive. You can have a mixed phenotype also. So I think basically managing rejections are crucial. Finding out the risk factors, which could lead to rejections, is very important to understand. And if we are able to treat those risk factors, I think the rejection prevalence does definitely come down. There are chronic rejections are difficult to treat. I would just put it in a simple way as compared to acute, because acute rejections can be completely cured, can be completely treated, but chronic rejections, once sets in, it's a long process. There's enough room to optimize, enough room to manage, and there are still a lot of research going on to for various modalities of treatment.
Okay, Chetan bhai, in the follow-up, once a patient goes home, what do you think is the importance of our simple spirometer, which we do even pre-operatively and for all chronic lung diseases, but specifically for post-transplant, what is the importance of spirometry?
So I feel spirometry is the most simplest and a non-invasive marker of any pathology in a transplanted lung, be it infection, be it rejection, be it stenosis, anything. So once there is a sudden dip in your spirometry values or your peak expiratory flow rate in an otherwise stabilized patient, it gives you a hint that something is wrong. Maybe the patient is still not symptomatic, but it is giving you a hint that something is wrong and you have to evaluate what it is. So it is always very handy. Patient can have it at home. Just a peak flow meter is what they need, and you have to have them monitor their regular readings on a book and then keep a track of it. Patient, and you can train the patient himself that any sudden dip in it, you have to come to us. So that is the easiest and a non-invasive method to identify any pathology in the
But
lung.
what is the frequency of spirometry readings which you expect the patient to do?
So peak flow meter every day, twice.
Okay.
But your in-lab spirometry is as whenever they come for surveillance, like 1 month, 3 months, 6 months, 9 months, and 12 months, and thereafter, like probably every 3 months or 6 months.
Okay.
So the first year is more aggressive, and later, depending on the clinical condition or depending on the symptoms, we take it a call.
Okay. Now, Vimy, Unmil did mention about chronic rejection, but I would just like to, in the entire explanation which he gave for rejection, I would specifically like to ask you about CLAD. Now, chronic lung allograft dysfunction. Nowadays, we've in fact got people, patients and recipients and families who go online, who read about this term, and then suddenly come and ask us, what is CLAD? Tell me more about CLAD. So if you could just very simply explain everyone, what is the meaning of CLAD?
So in transplant, there are two common words that we use. One is a chronic lung allograft dysfunction or a baseline lung allograft dysfunction. So chronic lung allograft dysfunction is something that we see after 3 weeks. And this is a common term, and it's a common term for a pulmonologist and the reference physician, which has to be very clear in the main concept. So it is briefly divided in a simpler way into two types. One is bronchiolitis obliterans or an BOS phenotype. Second thing, it is called a restrictive allograft or a restrictive phenotype or a RAS, restrictive allograft syndrome. So this is basically divided into obstructive and restrictive based on 2-3 important parameters. One, the foremost important is the spirometry, where we look at the FE1 by FEC and the classical less than 70%, etc. where we'll see an obstructive or a Boss phenotype having a classical obstruction. Second most important thing that we look is the CT picture, where a CT picture will be relatively normal in an obstructive phenotype. However, a restrictive phenotype will have many pleural based opacities or a CT based opacities. Other important parameter that we look at is the total lung capacity, where it is being reduced in a restrictive allograft syndrome or a RAS. So to understand the bottom line is one important parameter is the spirometry, and second most important parameter is the radiology and total lung capacity to understand the two main important phenotype. Having said that, there are unclassifiable phenotype, but two most important thing to understand is the obstructive and the restrictive phenotype. And in the acute setting, we have something called a baseline lung allograft dysfunction when it is not attaining more than 80% of the FVC.
Okay. Okay, Rahul. Now, there are a lot of people who have logged in, and, a lot of people keep asking that they want to pursue a career as a transplant pulmonologist. So, what all are the training options which are available for budding pulmonologists who are really keen to become a transplant pulmonologist?
See, though I'm been trained in KIMS Hyderabad, unfortunately, we don't have any formal training programs in our country as of now. We have few high volume centers like Hyderabad, Chennai have good amount of transplants going on, but there are no formal transplant training programs. But in worldwide, if you see the Toronto General University Hospital has a formal 1 month, 3 month observership or a 6 month and a yearly annual fellowship programs. Few centers in UK where you have done, I think the 2 years program is there. Few centers in Europe like Norway, Belgium, they have good transplant programs with a high volume centers. Mount Sinai is one of them in the US, but again that needs a USMLE. You need to clear USMLE before going over there. And one of the center in Sydney, Saint Vincent's, is one of the known centers for a transplant program, training program. So these are few options worldwide where we can approach to get enrolled for a transplant training.
Okay, perfect. Harsh bhai, I'll ask you the last question before I start taking questions, because there are a lot of questions which have come up. Now, we have always heard that interstitial lung disease is a surgical nightmare. So is it true? And how do you deal with the really dense adhesions which will occur, because this is a restrictive lung disease? So how do you deal with it?
Sir, not much. For thoracic community, it's not much of a problem because we deal with aspergillomas and all those stuff, and we are habitual of taking these additions down. So now most of these high-end devices like harmonics, scalpels, ultrasonics help us in doing these kind of dissections very easily, and we can proceed. The really a surgical nightmare, I'll tell you in a very common scenario. If a person has done a TALC fluorodesis in these cases, which was an absolute contraindication few years back, now it has become a relative contraindication. We have done 2 cases with the previous TALC fluorodesis in ILD cases. That is something which I will consider as a surgeon's nightmare, because the symphysis is like a wall to wall kind of a thing, and you just have to separate the lung from that thing. So except for that, most of the these thoracic surgical cases, because we are doing a lot of pneumonectomies for bronchiectasis, extensive aspergillomas and all those stuff, so they're okay for thoracic surgical community. Yes, you have to take care of blood loss and all those stuff, because you don't want to push a lot of blood intraoperatively to your patients. So you have to be very meticulous with your dissection, use a lot of energy devices, and you will come out well.
Okay, thank you so much. It's really reassuring, because what we've heard is, what I'm asking you, that it's actually a surgical nightmare. But thank you so much for that reassuring answer. So, as far as the panel questions are concerned, we've come to an end, but we've got some questions. People are constantly logging in. There are almost 1785 logins for today. So I'll just be asking one question per panelist before I ask for a concluding remark from each of y'all. Okay. So the first is, I'll ask Dr. Vimmi. So, Dr. Tridip Chatterjee from Mumbai is a very respected and a very senior pulmonologist. We all love him. He's asked a very practical question. What he says is, after great difficulty, we convince a patient for lung transplantation. But once the patient is evaluated, and the evaluation also is expensive, they are told that the patient is unfit for lung transplantation. So they have spent a lot of money, and eventually the answer is that they are not fit. So this is a big setback. So what can be done by the transplant team to improve this?
So we have come across the same scenario of the same, where we have a patient of an interstitial lung disease with a UIP pattern coming across a triple vessel disease or having a coronary artery disease with a renal dysfunction. So these are the few cohort that we see, and we tell them it is a high risk candidate for a transplant after a multidisciplinary discussion. So when we assess the risk benefit ratio, and if the benefit is not much and we feel that there is a lot of post-operative concerns and we are not sure about the different renal dysfunction which can worsen after transplant, these are the cohort of patients we tell them it won't be a right candidate. However, these are the patients who will still be on the rehab program, and we tell the referring pulmonologist it is a high risk, but he can still be on the rehab program, and the medical optimization as being done by the referring pulmonologist can still be continued, and he's being motivated to continue the same. So it is always to assess the risk benefit and take the final call.
Okay, got it. Now the next question I'll ask Rahul. Rahul, now I'm combining two questions basically over here, because both these questions are about donor management. Now people have asked, so we are non-transplant pulmonologists. When there is a brain dead donor in our hospital, should we ourselves perform the bronchoscopy, or should we wait till the transplant team comes? That's the first question. And second, if they are doing BAL, what samples should they send?
So ideally, they should do the bronchoscopy as early as possible to send a BAL culture. They need to send gram stain, ZN stain, BAL culture, fungal stains also, and gene. More important is gene expert in our country, BAL gene expert. These are the things they should send as early as possible, because it takes time. It will take at least 2 or 3 days to get the cultures. So if we get a confirmed culture, that will help us in deciding the acceptance or rejection of organ.
Okay.
So I would say they should ideally go for a bronchoscopy as early as possible.
Okay.
And to clear up any mild, if it is to begin with, if it is a mild aspiration at the time of admission, if they clean it up at the earliest, that will prevent a further significant aspiration pneumonitis. So they should do it at the earliest. But anyways, the transplant team can do it on table also again.
Okay, Chetan Bhai, there is Dr. Komal Pandey from Rajkot. She's asking, in post-transplant patients, what is expected from the original pulmonologist?
Okay, so as already discussed, we as a transplant pulmonologist prefer to have a close follow-up with the patient at least for the first 3 months. And after that, we tend to refer them back to their primary referring physician. So ideally, what we expect from them is to identify issues early. Like you can't be a bit casual like we do with our regular patients, like try one, then next. So you can't be that casual. You have to be very aggressive when they have symptoms, and at least know the basic management of immune suppression, how to monitor TAC levels, what are the target levels, target TAC levels, and what are the red flags, especially on spirometry, to pitch in a diagnosis early. If they are aware of this, I think rest all can be a mutual communication and be managed very well.
Okay. Unmil, very interesting question. Dr. Ajay Lanjewar from Nagpur is asking, what if the donor has untreated pulmonary tuberculosis in the past? What will be the risk of TB in the recipient?
So untreated pulmonary tuberculosis in the past, I believe that he does not have an active tuberculosis right now. Okay, it's just probably a post-TB sequelae or maybe. So I think if you have a donor X-ray or if you have a donor CT scan available, preferably that would guide us about whether there are any post-TB sequelae, or whether there are any fibrotic nodes or fibrosis in the lung or whatever. Specifically, when you open the chest as a part of a donor assessment, the surgeons would definitely palpate the lungs and see the surfaces and see whether there is any nodules, fibrotic nodules, or any doubtful nodules. How is the pleura and stuff like that. If there is any doubt regarding a nodule in the lung, you can always do a frozen and get an idea about it, before the lungs are retrieved. And specifically, sometimes, once, and obviously we will do a BAL where extensively, as Rahul mentioned, we'll look for the gene expert. If there is any past history of TB, definitely do send a TB culture also, because by the time, 6 weeks, we will get an idea. So if it's a past history of tuberculosis and if it has been adequately treated, and if it is just a scarring, should not matter much. Okay. But if it's an untreated TB, in the recent past, probably one has to be very careful taking such lungs.
But then I do believe that the history of treated and untreated is very difficult, right? Especially
difficult, yeah. So if it's an untreated TB in the past, how would it get cured? So if it's like the history taking is very important. Yeah.
Harshvardhan Bhai, there is an interesting question. Dr. Sujata Sharda from Latur is asking, if a patient gets registered for lung transplant, how much time does it take to get a donor?
So it usually depends. It completely depends on the luck of the patient. Maybe he will get a donor in next 24, 48 hours, or may have to wait for. Average waiting time in India, I guess everybody would agree, is from 1.5 months to 2 months. That is the average waiting time, but it can be more than that. It can be less than that, because there are a lot of the super sick recipients also. Geographical proximity also takes a precedence. So a lot of juggling is there at the Noto side, but the average waiting period in India is around 2 months, I guess.
Around 2 months. Okay. Now, Unmil Bhai, actually, I asked you the question about TB. Dr. Ajay Lanjavar has mentioned that it is actually unrevealed pulmonary TB in the past, but I think you have adequately explained, as to how the.
So if the CT scan shows any suspicion, then probably we have to be very careful, because at that time the history may not be available. The family is also grieving and it's difficult to extract a history. So I think one has to be very careful, evaluate the radiological part and the cross examination once the chest is open.
Okay, perfect. And my last question I'll be directing to Vimmi. Vimmi, this is my friend Kishore Gupta from Gujarat. He's from Ahmedabad. He's asking, what is the importance of minimal gastric symptoms in an optimized patient for timing of surgery? Should we wait more till the patient is completely asymptomatic?
So this is the common problem that we come across all patients with a connective tissue disease. So these are a subgroup of patients whom we usually undergo an upper GI endoscopy and 24-hour manometry, where we try to understand the different paralytic pattern or an aperistalsis in the different segments. So why it is very important? Because proper management of these gastric issues pre-transplant, it is very vital to prevent the chronic rejection post-transplant. So we have patients where it is found to have an aperistalsis with the scleroderma, whom we have kept on the waiting list and finally declined for a transplant, to someone who has a very large lower esophageal junction, who has undergone something called an anti-reflux mucosal ablation to reduce the size to prevent the gastric microaspiration. So gastric symptoms is very important, and it has to be dealt in a very systematic way to understand the different peristaltic and the muscle component and the different reflex symptoms pre-transplant, because it really affects the post-transplant success from a chronic rejection and other gastric symptoms point of view, because most of the drugs that we give will have some effect on the gastrointestinal system.
Okay, perfect. So I think that's the end of the audience questions. Now I would just like all of the panelists one by one to just give something like a concluding remark for so many people who have logged in. So we'll start with Dr. Unmil.
Yeah, so I think I would conclude by saying that the early referral and a good donor lung management both are the recipes for a successful outcome post transplant.
Okay. Dr. Harshvardhan?
The same, the patient should be referred early so that the outcome can be controlled and it should be a good outcome. And the other thing which I want to appeal to everybody, all 1,700 logins, let's tonight or maybe by tomorrow, if we haven't done, go to the Noto site and pledge our organs for donation. If we are asking for something, we should be able to give it to the people.
Great message. Great message. Dr. Vimmi?
So, lung transplant surgery is just one part, but the pre-transplant and the post-transplant care is very important, where all the pulmonologists have a very important role to play, and that will improve the success after transplant.
Okay. Dr. Chetan?
Yeah, so I think there's a lot of scope to create awareness among the referral physicians or pulmonologists in India, because most of the patients come saying we've asked for transplant, but the referral physician says transplant scenario in India is not good. Let me tell you that we are doing a great job and on par with the Western counterparts. India is really ready for lung transplants. Kindly refer patients early.
Okay. And lastly, Dr. Rahul, if you could also give your concluding statement, and then if you could just conclude, this webinar.
So the point we didn't discuss about the age of the upper age limit for the transplants. So we see a lot of patients who are in the elderly, like late 60s also and early 70s also. Those who are fit enough and those who are motivated enough to go for a transplant, so they still can be offered a good quality of life and good prolonged survival. So these patients can also be given option. That would be my concluding remark. And when we are discussing about progressive fibrosing ILDs, any discussion won't be complete without discussing about the lung transplants. So I would take this opportunity to thank the Indian Chest Society and their office bearers, respected Dr. Sandeep Salve sir, Dr. Amita Nene ma'am, and Dr. Raja Dhar sir, for giving us all of us this opportunity to discuss about this important topic of lung transplantation. And our the speakers, Dr. Kapil Iyer sir, for the lucid his speech and about his on-song moderation, and to our Dr. Harshvardhan Puri sir for his fantastic presentation, and our panelists, Dr. Unmil Shah sir, Dr. Vimi Varghese sir, and Dr. Chetan sir, and last but not the least, Dr. Our academic partners, Mr. Harshal, I guess, Mr. Harshal from SIPLA, for their continuous support for academics. So, and one more thing, I would like to invite all of you to our NAPCON 2025 to be held in Pune from 23rd to 26th Jan. And we will be having a separate lung transplant and ECMO workshop for our the colleagues. So all of them, as much as possible, they should attend, and we should make it a big success. Thank you, everybody. Thank you.
Thank you.